So I'm happy to present this to you, a little bit of information on the indications we are considering that are, there's probably many more, but what we are considering right now and where we have non-clinical data. And also I'll tell you quite a bit on the major unmet medical needs in these areas. So when it comes to osteoarthritis pain, you've all heard of it, and you know that you can buy ibuprofen or diclofenac or naproxen to treat your pain, but there's still a huge unmet medical need. Pain starts mostly when you start for physical activities or if you've been too physical in your activities. And later in the disease, you may also have pain during rest and during night. And pain at rest is more common in hip OA. Of course, it's not only knees that can have osteoarthritis, it's also other joints in your body. And swelling and edema is also a problem for these patients. So osteoarthritis, as Martin mentioned, there's more than 1.5 billion people worldwide, according to the WHO Global Report on Disease. And in the US, it's definitely more than 14 million adults that are affected. Symptomatic OA is about in 10% of men and in 13% of women above 60. Not only the knee, as I mentioned, can be affected, but also other joints, hip, spine, hands. So there's a number of different sub-indications in this group as well. And the older you get, the higher the risk is that you actually develop osteoarthritis. Of course, you can have joint replacements, and quite a few people do, but many want to wait for as long as possible. And for some, in some areas, it's not really an option. You can have to wait for several years before you actually qualify for surgery. There's a number of current therapies. I'll tell you a little bit more about those. And also there is a risk for side effects in older individuals. So the higher the risk is that you have osteoarthritis, the higher also is your risk of having side effects with current therapies. So what's in people's pharma cabinets at home now? Of course, exercise is core treatment, both to reduce stiffness and to reduce pain, and very often it's the last resort for patients to actually exercise. Weight reduction, because you have an increased risk of OA if you are heavily overweight. So pharmacological treatments should always be combined with exercise. High-level recommendations actually only for oral non-steroidal drugs like celecoxib, for instance, or ibuprofen or naproxen. High-level evidence is also available for articular injections of corticosteroids, but everyone doesn't want to do that, and you don't repeat it too many times. Other drugs actually have the indication, but it's a weak level of evidence. The effect size is not very large. Topical treatments are not recommended, nor are strong opioids, though quite a few patients actually receive them. So what are the side effects? What are the downsides with the current treatments? Because if current treatments were perfect, there would be no need for a good treatment, for a new treatment. So a lot of people actually have non-steroidals give them gastrointestinal problems like gastric ulcer, gastritis, diarrhea, nausea. It's about 1/4 of patients, and they actually stop taking the drug due to this. Another 1/4 of patients stop taking them because they don't work at all. In elderly patients, they're extremely much more sensitive to kidney problems. So a large proportion of patients, older patients admitted to hospital, are so because of drug side effects due to non-steroidals. And this is quite unknown, but it's actually a very costly problem for healthcare. Paracetamol has very few side effects, but also very low efficacy. Opioids, patients get constipated, nauseated, they get dizzy, they fall over, etc. And they have an impaired cognition and probably forget their doctor's appointments. So what happened to the NGF antibody story? Because like 15 years ago, monoclonal anti-NGF antibodies were developed, and in phase 3 of clinical development for OA pain and for neuropathic pain, and also for cancer-related pain. The effect was absolutely stunning, and it was dose-related. But during the development of Pfizer's, which was a frontrunner of all these projects, the tanezumab, they had some patients developing something called rapidly progressing osteoarthritis. And it could be, that was quite unexpected, and it was mostly in combination with nonsteroidals, and nonsteroidals were then a rescue treatment. So if the drugs didn't work, they took nonsteroidals. So this rapidly progressing away, it was dose dependent. So the lower risk, the lower efficacy. And thus, as a result, anti-NGF antibodies never reached the market because agencies considered that the benefit did not overweigh the risks of this drug. However, they've now been applied in pain management for cats and dogs. So the anti-NGF antibodies have validated our target as a relevant pain treatment, as in ACD137. And we can then, as we will tell you later on, we can avoid the adverse effects seen by the antibodies. So how does then ACD137 differ from NGF antibodies? Of course, that's key information because the problem today is largely safety. So the NGF antibodies, they act, it's released, NGF is released at the site of an injury. If an injury, whether it's peripheral injury or it's an inflammation in the joint, then the TrkA is a receptor for this nerve growth factor, NGF. And it's located on the neuron, the sensory fibers that make you feel pain. And there's also receptors on the immune cells. So you get swelling and you get pain. Now, NGF leads to this inflammation and pain, and the anti-NGF antibodies inhibits this. But they also inhibit some other pathways in the pathway from NGF to the general inflammation, etc. So what happens is that the anti-NGF antibodies are very unselective. So we say that ACD137 is a TrkA receptor negative allosteric modulator. So the NGF antibodies, they stop the NGF, which are very important also for nerve growth, so for reconstitution of injured. They give a pain signal, but they're also important for the restitution of the tissues. But they also take the pain away through the TrkA mechanism. Our drug doesn't take the NGF sort of the inhibitory effects. It only treats the pain part, which is the TrkA. So we avoid all the side effects that were seen with the antibodies that we know now are related to this so-called P75 receptor. So ACD137 can treat pain and stiffness. They can treat pain signaling, and that will improve mobility and wellness because quality of life is also a very, very important piece of the puzzle for these very many patients. So I will go further into another indication which we think is very timely, very important, and clearly underserved. And it's a type of peripheral neuropathic pain that is induced by chemotherapy, so cancer treatments. This is a growing patient group. So in 2023, the 5-year survival of cancer was 85% or more in 25 countries in Europe, North America, Oceania. In the US, the 5-year relative survival rose from 75% in the 70s to 90% in 2016. And now the survival rates for the most common and for the most aggressive types of cancer, survival rates are between 99 and 100%, which is quite impressive. That's not what we learned 20 years ago. And I think that's also very much what's in the back of our minds when we think of cancer. So a very important reason for this is the screening programs that have been implemented, at least in the Western world, as well as also improved treatment regimens. Considering the increasing yearly incidence, not the least breast cancer, prostate cancer, colon cancer, and lung cancers, which are the 4 most common kinds, the number of individuals is still increasing because there's more patients who have cancer, Many are caught in screening programs, and many more survive more than 5 years. That means that there's a growing group of people who suffer or can suffer from chemotherapy-induced neuropathic pain. Actually, this group is growing so fast, so there's no really good epidemiological data of how many they are. We just know how many are diagnosed and how many are treated per patient group. But it takes those are longitudinal studies, and data is actually developing over time. Pain after irradiation treatment for cancer is high. In ENT cancers, so ear, nose, and throat, is about 38%, and in general, it's between 30 and 40% of colon and breast cancer are the other two indications where radiation is a common treatment. When it comes to chemotherapy-induced neuropathic pain, overall, it does differ between the different chemotherapeutic agents and the type of malignancy. So the intensity of this pain, of the chemotherapy-induced neuropathic pain, often sets the dose limit for chemotherapy. If patients have too much pain, you have to stop dosing and wait until it wanes a bit. So if we can reduce this pain in the acute situation, we could actually optimize the chemotherapy and thereby increase effects further. So chemotherapy-induced pain is very intense in the acute phase. It often attenuates over time, but remaining provoked symptoms can last for very many years in combination with the loss of sensation. Patients can say that it's like they're walking on pins and needles, or walking on Lego pieces if you have them at home, or on coal, depending on how they are. But this is the typical mix. They require steady shoes because they have a loss of sensitivity, and in combination with pins and needles and provoked by cold, even at normal ambient temperature. A typical patient looks like this because patients come and they draw a pain drawing, and what they demonstrate is something that we call a sock. So this is where the pain is, sock and glove distribution. That's very typical. And when the doctor examines the patients, they can say that, okay, you have a loss of sensation here, and that's where we have all these crosses back and forth with the lines that are perpendicular and the cross. And then most of them also have so-called hyperphenomena. So that means that you can elicit pain with cold or with pinpricks, but especially cold in these patients. In the summer, they can sleep with their warm socks on, just to be able to sleep and not be in pain. So what is the current standard of treatment? Same treatments as for other peripheral neuropathic pains is actually used. So it's serotonin, norepinephrine reuptake inhibitors, so duloxetine, gabapentinoids, tricyclic antidepressants, and they have a very poor efficacy, less than in other neuropathic pains. It's not good in the other types, but it's even worse here. It's like 1 to 12 to 15 that you have to treat. So treating 12 to 15 patients to have one with sufficient analgesia is not a very good treatment result. Many patients just need to have better coping strategies, which is tough. There's few studies actually dedicated in chemotherapy-induced neuropathic pain on clinicaltrials.gov. So one study funded by the NIH demonstrated a significant reduction of pain versus placebo. But two ongoing studies are one now 1.7 channel and one calcium channel blocker. We don't know what happens with those. They still have another year to go. And there's one completely negative study with pregabalin. One reason that we don't know more is probably because the grading systems that is used in oncology questionnaires, they don't even ask about pain. They ask about function. Can you handle yourself at home? Can you cook? Can you hold a mug? Can you do your toiletry as you should, etc. So this is not really measuring the problem. But one study actually looked more into this, and they looked at patients who had been treated for colorectal cancer. And it turned out that this was after several years, 9% of the survivors had painful neuropathic pain, and 9% of all those patients who have been treated for cancer, that's quite a few, and non-painful chemotherapy-induced neuropathic pain was reported by 22%, and those 22% also include those with evoked pain, so with stimulation-induced pain. Time since diagnosis was related to chemotherapy-induced pain, and it can actually start a couple of years after end of treatment. Higher disease stage, so higher total dose of chemotherapy is, of course, important and related. And survivors with painful chemotherapy-induced neuropathic pain, they report a much worse global quality of life. So it must be painful chemotherapy-induced neuropathic pain must be distinguished from non-painful patients, as they say only painful patients were related to worse quality of life. I think it's probably a little bit of modification here, because I think they missed a few in the 22% that were actually suffered from stimulation-evoked pain. I will not tell you more about this, just a list just saying that there's quite a few, almost all of our most common chemotherapeutic agents, they actually cause neuropathy. It's just very well known, and it's how, the symptoms of neuropathy is what drives your maximum dose. So the same as with osteoarthritis, and that my colleague Pontus Forsell will tell you quite soon as well, is that NGF antibodies, they've shown promise in alleviating pain, also in chemotherapy-induced neuropathic pain, but they were halted because of the side effects that were found in the Pfizer program. And it's not because of the Pfizer, because it was there's a target-related problem with the NGF antibodies being unselective and not being only effective on the TrkA, which is the part of the NGF downstream activity that is related directly to pain. So this one I already showed you, just for remembering. And so in summary, OA pain affects more than 500 million people worldwide, and it increases because the aging population increases. Current therapies are not very efficacious. They have limited tolerability. Chemotherapy-induced neuropathic pain is growing. Very few have an effective treatment. 9 to 10% of the patients develop chronic neuropathic pain. And it's specifically sensitive to thermal stimulation. Current treatments don't work well. And based on the data with NGF antibodies, there's a huge amount of data in patients with NGF antibodies. It's a validated target because the efficacy was very, very good. But NGF is a validated target for OA pain and also for chemotherapy-induced neuropathic pain. So we believe that ACD137, not having the side effect profile of the NGF antibody, is a very promising candidate for the treatment, both of acute and chronic neuropathic pain.